So, quick thing, contrary to popular opinion and contrary to the way that a lot of things are now, I would say there are a lot of medical professionals, healthcare professionals who got into healthcare to heal people. And when I say that, I mean like for people to actually get better, for people to have better health. And I think a lot of the frustration in care delivery comes from having that desire to heal people and heal communities and make people better, and having to jump through all of these hoops that don't seem to contribute or support that passion, that desire that we have for patients and communities to do better, to feel better, to have better health, right? To have lower blood pressure, to not have exacerbation of chronic diseases, to be able to have children and be healthy and not die of sepsis tomorrow over some simple nonsense, right? There are a lot of hoops to jump through, and we know that, right? We know about quality reporting, we know about billing, and we know about coding and all of that stuff, right? And how our system and the interventions that we have to do, like outside of caring for the actual patient, doesn't necessarily align with making it possible for us to truly partner with patients for better outcomes. But let me just let you know right now that there is serious hope, because things are changing, and things are changing in a very, very good and very exciting way that I am looking forward to sharing with you all. Fee for service, you get paid by performing interventions, right? Like you take a temperature. It doesn't matter how high or low that temperature is. You take a temperature, you take a blood pressure. It doesn't matter what the blood pressure is. Or you prescribe a medication. It doesn't matter how well the medication works. You perform the intervention, right? You do the assessment. You spend X amount of time with the patient at the bedside, right? An intervention. It has nothing to do with the quality of it. It has nothing to do with the results, but we get paid based off of what we do. And of course, the billing and the coding have everything to do with that, right? The CPT2 codes that are submitted have everything to do with that. The ICD-10 codes that have to be linked with those, with the other code, that everything to do with it. I'm not going to talk about inpatient DRGs or diagnostic related groups, but at least in the outpatient world, let's just stick with outpatient for now. There's a lot, and a lot of it is based off of intervention. It can be frustrating, right? Because again, there's that juxtaposition between what you want to do, which is not just intervene. It's not just charting, but you want patients and communities to get better. And charting doesn't seem to help that, does it? You know what I mean? So yeah, jumping through hoops in order to just make the impact that you want to make. And I think that that has a lot to do with burnout as well. I think burnout is more than just clicks. Like people are talking about, oh yeah, like the providers and the nurses, they hate clicking around and blah, blah, blah. You want to be with the patient, duh, of course. But then at the same time, we're also talking about like the staffing shortage, and we're just like, okay, we have very few. And right now, the solution that I keep hearing is about getting more providers, getting more nurses, getting more people at the bedside, or getting more bodies out in the field in order to address the staffing issue. But what I am not hearing is anything about technology and how technology makes it possible for us to scale, how technology makes it possible for us to do more with less, to make a bigger impact with less. I do feel like we have a duty to pull those levers as well. I'm not saying don't hire people. Obviously, I'm not saying that. But I am saying that we need to optimize how we can scale better outcomes for people based off of what we have now. What can technology unlock in this area to make that possible? I dedicated my entire career really to value-based care and health equity. Value-based care should be tied with patient outcomes. One example of an outcome would be a patient going from having hypertension to no longer being hypertensive. That's one example. I'm going to keep going with this. I'll use that as an example of what it takes to achieve better outcomes and how it makes sense to reimburse or to pay based off of performance and how well or consistently providers are able to secure those outcomes. So high blood pressure, we already know. Hypertension is a silent killer. We know that a person can be walking around with high blood pressure and not even know it. Their end organs are being assaulted constantly. Their kidneys are struggling. Their vision is changing. All sorts of stuff is going on, right? They might even be pregnant. Oh my gosh, like hypertension is a big deal. Uncontrolled hypertension is a big deal. Now let's touch on like all the things that go into partner with the patient to where they go from being hypertensive to where they are normotensive, okay? Depending on where they are, say they have uncontrolled hypertension. We know, you and me, that it starts with first thing we say, what? Lifestyle modification. And that is after, I'm not even talking about I'm talking about you have diagnosed confirmed hypertension and you're moving down. So we're past the measure accurately, act rapidly. We're in the partner with patients part of MAP. I'm literally just talking about, yes, we have confirmed that this patient is hypertensive. We know that. We're talking about lifestyle modification. Lifestyle modification has a lot to do with movement and exercise, which isn't easy. What are we going to do? Just wave a magic wand and be like, okay, now your life has changed. Bam! Nah, we can't. Really? Anyone who has tried to lose weight and keep it off understands that lifestyle modification doesn't just happen by sheer willpower for most of us. For most of us, it does not just happen that way. So there's lifestyle modification that needs to happen. And lifestyle modification requires planning, it requires strategy, it requires building trust in oneself, it requires motivation, it requires buy-in, because you're not gonna modify someone's lifestyle. We modify our own, you know what I'm saying? So there's that, right? There's also food, which I consider under lifestyle modification. Anyone who has ever tried to eat healthier will understand that, again, you can't just wave a magic wand and expect a patient or just tell a patient, oh, modify your food, and expect them to just magically, oh, I eat perfectly. Nah, not happening, right? So that's under lifestyle modification too. You might have a patient that needs medication. There's a level of medication compliance that's needed, but then also, again, that patient might have to jump through hoops. Another thing, we have to be honest about the patient's experience as well, right? If the patient feels fine, right? They take this medication, if they're even able to access it, and we know that's a whole kit and caboodle right there. If they're able to access their medication, they might have side effects from that medication permanently or for a while. And they might ask themselves, why would I take this medication if I feel terrible when I take it, and when I don't take it, I feel fine? And why would I? You see what I'm saying? So there's a lot there. So again, from uncontrolled hypertension to normotensive, there's a lot. Again, there's lifestyle modification, there's diet, which is under lifestyle modification, I think. There's medication compliance. You might have remote patient monitoring, but then you also have to deal with outreach and access and communication. How are you going to partner with that patient? And if all those stars align, and you are truly partnered with that patient, you might see that patient actually gets better. And then all of a sudden, you're just like, oh, wow, that's awesome. I partnered with providers who partnered with patients who achieved these results at scale. And I'm talking about at scale. Received recognition from Target BP, received recognition from the Center for Disease Control with their Million Hearts campaign in some of the most unlikely markets, including markets in Louisiana where they eat boudin and a lot of other delicious things, right? Folks were very, very surprised at what it truly took operationally for that needle to move, and what it did not take, what was not required, what was not needed, what was unnecessary to achieve that outcome. But it was so cool how, like, when the patients got better, how practice providers and their whole practice staff, things changed for them. They weren't just on a hamster wheel of interventions and making money while people were just staying sick. Like, people were like dropping off flowers and inviting them out to lunch and all sorts of stuff. And on top of that, their payment structure was one in which it was aligned with them being compensated based off of better outcomes for the patient. So it got really, 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 really exciting. That's the world that I came from. So here is a little bit about what's on and popping and what's going on. CMS, Center for Medicare and Medicaid, has come out with this. This did not come out of nowhere. Before I move on with explaining access, I'm going to focus on the scalable part. Because last time I checked, we are not one-to-one providers. We don't just have one patient. Nurses don't just take care of one patient typically. They take care of one patient at a time. Same thing with medical providers or MDs. We'll take care of one patient at a time, and then we'll be insulated by HIPAA, which is wonderful, right? But we need systems because we don't have one patient. We have a patient census. We have groups of patients who are all unique and have unique needs in unique settings and communities with certain circumstances. That is where the complexity comes in. In school, yes, we learned how to take care of a patient. Understand? We learned about diagnostics, we learned about assessment of a patient. But it's not until later on, at least for me, it was like on the master's level, to be honest with you, where we talk and learn more about taking care of more than one and what it takes for a system to deliver care consistently at that level. And even then, it's not outcome based, even then, okay? But that is why we need solutions that scale, where whole communities, whole cohorts, whole sensi can actually achieve better outcomes, right? at scale. And that's only possible with technology, which is literally for scaling like this. So it gets really, really exciting. If you're in the inpatient space and you're hearing me, because you might be hearing me from the inpatient space where a lot of this does not pertain to you in the inpatient space the way that it does to those in the outpatient world. You understand, right? For us, it reminds me of the 30-day readmission. 30-day readmission is our benchmark that is tied to reimbursement, right? So if that patient comes back under certain circumstances, is unplanned, no matter what diagnostic related group they were discharged with, when they come back, if it is unplanned, then you get dinged and you get less reimbursement. Reimbursement is how you are paid in the inpatient world, right? That started out with just chronic conditions, and then it expanded to be other conditions as well. Now across the board, even for sepsis, okay, which probably, depending on how it starts, but even with sepsis, you have a 30-day readmission penalty that hits your bottom line as a healthcare organization. I see this doing the same thing. What this access model is doing, essentially, is it's incentivizing better care. So if you're one of those people who went through school to care for people, right? Went through clinicals, went through residency, went through all this stuff, jumping through hoops. You might have even been in an ACO or two. You know what I mean? Like, you are one of those people, right? This should get you really, really excited. You can have your cake and eat it too, finally. This is the beginning of that. This is just the beginning of a newly aligned system where you actually get paid when your patients get better. And I think I'm all for it, man. I am all for it. I'm going to take it a step further because this here is talking about to expand access to technology-supported care options that help people improve their health and prevent and manage chronic disease. What I'm excited about is excited about that is it's talking about technology that already exists, which is really, really exciting. Technology that exists to help patients achieve these outcomes, right? To measure it, but also technology that actually supports the providers of the care too. Technological support for care delivery that is not burdensome, but also support for patient outcome measurement and patient experience, patient betterment, being able to partner with the patient, because you actually have to partner with patients in order for this to be possible. I keep hearing people talk about technology, and I keep hearing about people in trust, right? Trust of technology. And a lot of providers choose not to leverage technology because they don't know what technology to trust. Understandably, because there is a lot of crazy nonsense going on out there, reckless stuff, just nuts. This model with the right technology will help practices, providers become more trustworthy, to be honest with you. Because patients need to know who they can trust. And I think trust, for me as a patient and as a parent with patients, part of trustworthiness for me is competency. Can you actually do it? Can you partner with me? Can you actually partner with me? Or are you too burnt out? Can you measure? Are you able to diagnose accurately? Do your treatments actually work for me and fit my context? Does it work with my situation? Where's the value of it? But if you can actually help me control my blood pressure sustainably, I think you grow in trustworthiness. More to come, more exciting developments regarding this access model. Again, I will place these resources here in either the description or maybe like the first comment below. If you found this helpful, feel free to like, share, subscribe. Bottom line is a new day is coming, and it's actually already here, and it's freaking awesome. It's time to giddy up, y'all. I'll catch you on the other side.
Look out for new updates.